Welcome to NU 623 Adult Healthcare Unit 5 Presentation 3 on Adrenal Disorders. Please make sure you do read the corresponding areas of your text that have to do with the diseases in this presentation because endocrine diseases can be very confusing and there's a lot of things to remember. Also, if there is any course module links, please click on those and review the information suggested as well. Please look at the clinical presentation signs and symptoms for Cushing syndrome and Cushing disease because they have a very similar presentation. Cushing's disease is typically caused by a pituitary adenoma. You're going to see more of a gradual onset. Think about these signs and symptoms as all being related to excess cortisol and androgens. And Cushing syndrome is caused by an adrenal excess cortisol due to adrenal cortex hypertrophy or tumor. Classically, you're going to see the central obesity, the moon face, the buffalo hump, the thinning and bruised skin in the striae, proximal muscle wasting, and they could have presented to you for pathologic fractures or osteoporosis. On the differential diagnosis, you're going to be trying to figure out other disorders that could increase the cortisol levels. You're likely just going to do initial testing, and the remainder of testing is going to be done in collaboration with an endocrinologist. So your first line test is going to be a late night salivary cortisol, and you're going to want to do this on 2 separate nights. If they're positive, which means the value is greater than the upper limit of normal, you're going to confirm this with a 1 milligram overnight dexamethasone suppression test. A positive AM result for cortisol would be greater than 1.8 on this test. Or you could do a 24-hour urinary free cortisol, which a positive result would be greater than 50 micrograms in 24 hours, but the urine cortisol sensitivity is a little bit lower than the other 2 tests. A CBC should be done. You will often see leukocytosis. A CMP would show hypokalemia due to impairment of glucose tolerance. Subsequent tests that could be done is the DHEAS, which is elevated but non-specific, but it could point you to a source such as an adrenal carcinoma when it's accompanied with accelerated virilization or Cushingoid type signs. ACTH can be done, and this is assessed after Cushing syndrome would be diagnosed. You're going to see an AM reading of greater than 20 pictograms if there's a pituitary or an ectopic etiology, and if it's an adrenal etiology, you're going to see a value of less than 5. When you CAT scan the adrenals, first line, you're going to do this if the ACTH was suppressed, and then it's going to show sensitivity to detect adrenal adenoma, a hyperplasia, or tumor. If your ACTH is elevated, then your MRI pituitary test is going to be your first line because you are looking for a pituitary adenoma at that point. CT abdomen, pelvis, and chest might be done if you have not found a tumor source because there can be ectopic ACTH producing tumors. Management is aimed at treating the underlying cause and normalizing the cortisol levels, which can be done either through surgery, radiation, or with medications. If a patient has to undergo an adrenalectomy or a pituitary resection, they're going to require exogenous glucocorticoid therapy, and this may be a 9 to a 36-month type of treatment plan, and it'll be addressed by the endocrinologist. They usually use either hydrocortisone, prednisone, or flurgicortisone, and you can see in your book on page 905 in table 57.3 the drugs commonly prescribed, and it will list those drugs indication and the adverse reactions and prescribing considerations for each. Patients who are non-surgical candidates may just be given medications to decrease cortisol production. These can be used together or they can be used alone. Mitotane and ketoconazole are those drugs. Keep in mind with ketoconazole that you have to monitor liver function with that. Follow-up, it's going to be done probably between you and the endocrinologist, and you're going to monitor for infections or complications. They're going to be seen monthly for the first 12 months and then go on a schedule of every 6 to 12 months after that. As far as referrals, endocrinology definitely needs to be involved. They can help establish the diagnosis and the treatment plan. A surgeon may need to be involved if there needs to be a adrenalectomy or a pituitary resection, and that'll depend on which type of surgeon you consult. And then an oncologist may or may not need to be referred as well in this case. Adrenal insufficiency can have different presentations. We're going to focus on Addison's disease, which is primary adrenal insufficiency. This is where there is inadequate secretion of corticosteroids due to some type of destruction or partial destruction of the adrenal glands, whereas a secondary adrenal insufficiency is a pituitary origin and tertiary is a hypothalamic origin. Presentation is going to be pretty much opposite of your Cushing's syndrome. Patients are going to be smaller, they have weight loss, they're not wanting to eat, they may have abdominal pain and diarrhea, they're going to be weak and fatigued, blood pressure is going to be low, sugar is going to be low, they're typically going to have hyperpigmentation of the skin, and in females you'll see a loss of secondary sex characteristics such as the pubic hair and the axillary hair. Differential diagnosis is going to be to figure out if this is coming from a primary or Addison's disease, or if it's secondary or tertiary cause of adrenal insufficiency, or things that have nothing to do with adrenal insufficiency in general, such as malignancy or a thyroid issue, or maybe they're having an eating disorder. For diagnostic reasoning, the first thing you're going to do is an AM cortisol test. You want to do this between 8 and 9 AM. That's when the cortisol levels naturally peak in the body. If you get a test that's less than 3 micrograms per deciliter, this is suggestive of an issue with adrenal insufficiency, and you would follow this up by an ACTH stimulation test. If you need to confirm the diagnosis of adrenal insufficiency, the serum cortisol level of less than 18 done 30 to 60 minutes after receiving exogenous ACTH is an abnormal response, and it's suggestive of adrenal insufficiency, but it doesn't tell you exactly which type of adrenal insufficiency. You follow this up with a plasma ACTH level, and this can help to differentiate between at least Addison's and the other forms. If your plasma ACTH is greater than 100 points, this points to a primary adrenal insufficiency or Addison's, and if your value is between 20 and 100, it basically just excludes Addison's. A chemistry profile is not necessarily required for diagnosis, but you're going to see a typical pattern if you draw one: a low sodium, chloride, and glucose, increased potassium, and elevated BUN and creatinine. On CBC, you're commonly going to see neutropenia, lymphocytosis, eosinophilia, and a normocytic normochromic anemia. A CAT scan of the adrenal glands can be done, and this is either going to show a normal adrenal gland or small or atrophied adrenal glands. They can be enlarged or wither with calcifications too, but small and non-calcified typically are going to point towards an autoimmune Addison's disease. Patients are going to require lifelong physiologic doses of exogenous glucocorticoids. and mineralocorticoids. There is a maintenance protocol where they receive both. Hydrocortisone is typically the preferred glucocorticoid, and flurcortisone is typically the mineralocorticoid that they're going to receive. When in times of extreme stress, they may require double or triple maintenance of the glucocorticoid for about 3 days. Not necessarily an increase in the mineralocorticoid. When they have an adrenal crisis, they will require high-dose IV glucocorticoid and supportive care, so they'll be in the hospital for any adrenal crisis. Women who have also complaints of a low libido, they may be also put on DHEA supplementation. Make sure you look at the patient education on page 908. This is a very important component of management for these patients. Sometimes they are given protocols to do their stress dosing on their own at home, so they do need to understand the importance of their medications. The same is with the Cushing syndrome, and I didn't mention that earlier. Patient education is extremely important, so ensure that you do read that section of your text. In follow-up, they're going to be monitored very closely while the maintenance dose is being determined, and this is generally going to be established by an endocrinologist. You're going to monitor for any adverse side effects of chronic steroid use. Consider the effects of chronic steroid use, including cataracts and hyperglycemia, diabetes. Referrals are going to be made to endocrinology at the get-go to help establish the maintenance dose and possibly even to help establish diagnosis. Anytime there's dose adjustments or you want to change a class of hormone replacement, this needs to be done through endocrinology as well. And then ophthalmology needs to be in place with an annual eye exam due to the possibility of cataracts from the chronic steroid use. I can't stress enough that you do need to read these chapters in your book so you have a full understanding of these disorders. There's a lot more information that's covered in the chapter. And then please check out any resources that are in your course module that can help you.